Hello, everyone, and thank you for joining today's CMS Web Interface support call. During this webinar, CMS will provide an overview of the 2020 CMS Web Interface quality reporting for MIPS ACOs, groups, and virtual groups. After the webinar, CMS will take as many questions as time allows. Now, I will turn it over to Sandra to begin.
Thank you, Haley. Welcome, everyone, and thank you for joining us today as groups, virtual groups, and ACOs prepare for CMS Web Interface quality reporting. I'm Sandra Adams-Slaughter from CMS, an expert on the CMS Web Interface. Joining me on the call today are other experts who will share helpful information on CMS Web Interface quality reporting and answer your questions during the question and answer session after today's presentation. Today's call will only focus on 2020 quality reporting. Please note that any measure guidance provided during this presentation is specific to the CMS Web Interface. When using other collection types to submit data, you should refer to the measure specifications applicable to the collection type used. You can contact the Quality Payment Program Service Center with any of your questions regarding cost, promoting interoperability, improvement activities, MIPS, or quality reporting in general. Next slide, please. This is a disclaimer slide about this presentation. Information in this presentation is current at the time it was published, but I urge you to please be sure that you're using the source documents and links that are provided throughout the presentation. And please stay tuned to any communication from the Quality Payment Program, Shared Savings Program, or Next Generation ACO model regarding any updated information. Next slide, please. And next slide. The CMS Web Interface will close promptly at 8 p.m. Eastern Daylight Time on March 31st, 2021. Your submission will be automatically accepted once the submission period closes. As a reminder, the CMS Web Interface is accessible using the sign-in link on the Quality Payment Program website, circled here. Next slide, please. The materials from the January 27th, February 10th, February 24th, and March 10th support calls are posted on the Quality Payment Program webinar library. Next slide, please. And here's some reminders. The 2020 CMS Web Interface API is available all year for testing and developer preview environments. Please review the links listed here for more information. Next slide, please. We want to remind you that other CMS approved reason requests must be submitted through the CMS Web Interface. Requests should be reserved for circumstances that are unique, unusual, and not covered by any of the denominator exclusions or denominator exceptions identified in the measure specifications. Please review the 2020 measure specifications thoroughly before submitting a request to skip a patient. Next slide, please. Once you have submitted an other CMS approved reason request, additional information may be requested from you. If further information is requested, you will receive an email from PIMS Quality Measures Support at gbit.com. If the requests for additional detail are unanswered, the request will move forward in the review process using the information available. Once a decision has been issued, the request cannot be reopened. Submitting any requests for other CMS approved reason during the last days of submission could cause your request not to be processed. Please submit your request as soon as possible. Next slide, please. This is a reminder that the 2021 performance period is the last performance period that the CMS Web Interface will be available. We will be hosting transition webinars in the summer. The 2021 Web Interface measure specifications and supporting documents are available on the Quality Payment Program Resource Library. And now I will hand things over to Lisa Marie Gomez to go over the Extreme and Uncontrollable Circumstances application.
Thanks, Sandra. Next slide, please. And next slide. So we want to ensure that web interface users are aware of the flexibility we have provided for clinicians responding to the COVID-19 public health emergency. We are applying the MIPS Automatic Extreme and Uncontrollable Circumstances policy to all MIPS eligible clinicians for the 2020 performance period. The MIPS Extreme and Uncontrollable Circumstances application will be available through March 31st at 8 p.m. Eastern Time. We just want to note that Extreme and Uncontrollable Circumstances application submitted between now and March 31st will not override previously submitted data for groups and virtual groups if data has been submitted for 2 or 3 performance categories. For the next few slides, I'm going to review the applicability of the Extreme and Uncontrollable Circumstances policy to groups and virtual groups. Next slide, please. So now I'm going to discuss how the Extreme and Uncontrollable Circumstances policy applies to groups and virtual groups that have not submitted any data. For groups that are not able to submit data for the 2020 performance period, you will not need to take any further action. With reporting at the group level being optional under MIPS, the individual MIPS eligible clinicians within your group qualify for the automatic Extreme and Uncontrollable Circumstances policy. For all 4 performance categories will be reweighted to 0%. The individual MIPS eligible clinicians within your group will receive a neutral payment adjustment for the 2022 MIPS payment year, unless they submit data for 2 or more performance categories as individuals, or if the practice reports as a group by submitting data for 1 or more performance categories. For virtual groups that are not able to submit data for the 2020 performance period, you will need to submit an Extreme and Uncontrollable Circumstances application for all 4 performance categories to be weighted to 0%. Next slide, please. For groups and virtual groups that have submitted data for 1 performance category, you can submit an Extreme and Uncontrollable Circumstances application to request a reweighting of all performance categories as long as data has not been submitted for other performance categories. For groups and virtual groups that have submitted data for 1 performance category, you'll be scored on all performance categories if an Extreme and Uncontrollable Circumstances application is not submitted, unless you are eligible for reweighting in 1 or more performance categories. The MIPS eligible clinicians within a group or virtual group will receive a neutral payment adjustment for the 2022 MIPS payment year if your group or virtual group's Extreme and Uncontrollable Circumstances application is approved and data is not submitted for more than 1 performance category. Next slide, please. For groups and virtual groups that have submitted data for 2 or 3 performance categories, your MIPS eligible clinicians will be scored on all performance categories unless your group or virtual group qualifies for reweighting in 1 or more performance categories. The MIPS eligible clinicians within your group or virtual group will receive a MIPS final score and a MIPS payment adjustment for the 2022 MIPS payment year. We want to note that groups and virtual groups that have submitted data for 2 or 3 performance categories, the submission of an Extreme and Uncontrollable Circumstances application will not override any previously submitted data. Now I'm going to turn the presentation over back to Sandra, who will discuss the Extreme and Uncontrollable Circumstances policy and how they apply to APM entities. Sandra?
Thank you, Lisa Marie. Next slide, please. Okay. To submit an extreme and uncontrollable circumstance application for APM entities, you can reference the 2020 Extreme and Uncontrollable Circumstance Application User Guide on the Quality Payment Program webpage. Please note there is some difference in the extreme and uncontrollable circumstance policy for APM entities than from the MIPS Extreme and Uncontrollable Circumstance Policy for individuals, groups, and virtual groups. APM entities are required to request reweighting for all performance categories. More than 75% of MIPS eligible clinicians in the APM entity must be eligible for reweighting in the Promoting Interoperability performance category. And APM entities' approved application for performance category weighting will override previously submitted data. Also note that the extreme and uncontrollable circumstances application period ends on March 31st, 2021. As a reminder, all accountable care organizations are considered affected by the COVID-19 public health emergency, and the shared savings program extreme and uncontrollable circumstance policy applies. Next slide, please. We want to highlight that there are additional extreme and uncontrollable circumstance materials available on the Quality Payment Program website. And now I'm going to hand things over to Aslam Tazel.
Thank you, Sandra. Good afternoon, everyone. Can we go to the next slide, please? Okay, this is Aslam Tazel. I'm with the CMS Web Interface product team. Today, I'd like to provide an update on the measure rates report error. Next slide, please. In the last CMS Web Interface support call, it was brought to our attention that in the downloadable Excel version of the measure rates report, under the Prev 10 tab, the measure score displayed NA, and there was a note that displayed this measure does not have a benchmark. However, you have met the data completeness criteria by reporting data for all patients that were assigned to this measure. This measure will not be calculated in the denominator of your overall quality performance category score. Next slide, please. This issue is now fixed. If you look in the downloadable Excel version of the measure rates report under the Prev 10 tab, measure score now reflects the same score displayed in the CMS Web Interface application, and the note regarding the benchmark is removed. Next slide, please. The following applies to the 2020 Prev 10 measure. It is classified as pay for performance for the shared savings program, and it's included in MIPS scoring. There's an existing benchmark for the 2020 Prev 10 measure. The 2020 shared savings program quality measure benchmarks can be viewed at the URL listed on this slide. Next slide, please. Okay, I will now pass it to Angie Stevenson.
Hi, this is Angie from TIMS, and we're going to go over some frequently asked measure questions today. Next slide, please. So this is for the CARE 2 fall screening for future fall risk measure. The intent of the measure is to screen patients 65 years of age and older for future fall risk. The 2020 CMS Web Interface CARE 2 measure does allow screening for future fall risk to be completed during a telehealth encounter. Next slide, please. Our first question is, what clinical information should the medical record reflect to meet the intent of the 2020 CMS Web Interface CARE 2 measure? And the answer is screening for future fall risk is an assessment of whether an individual has experienced a fall or problems with gait or balance. A specific screening tool isn't required for this measure. However, potential screening tools include the Morris Fall Scale and the Time to Get Up and Go test. The numerator guidance in the measure specifications states that documentation of no falls would be sufficient. Medical record must include documentation of a screening performed. Any history of falls screening during the measurement period is acceptable as meeting the intent of the measure. The gait or balance assessment meets the intent of the measure. If, after reviewing the medical record, you find supporting documentation that meets the numerator guidance criteria, then it would meet the intent of the measure. Next slide, please. Question 2 is, if the patient is non-ambulatory at any time during the measurement period, can they be excluded from the 2020 CMS Web Interface CARE 2 measure? The answer is no. The patient would only be considered eligible for the denominator exclusion if they were non-ambulatory at the most recent encounter during the measurement period. Question 3, is documentation of an inpatient or emergency department falls screening acceptable for the 2020 CMS Web Interface CARE 2 measure? Yes, the measure isn't limited to a particular setting. Question 4 is, who can perform the falls screening for the CARE 2 measure? The answer is the measure is not limited to a particular clinician type. The quality action can be completed by anyone the organization considers qualified. And with that, I'll turn it back over to Sandra Adams-Slaughter at CMS. Thank you.
Thank you, Angie. Next slide, please. The next few slides will outline the available CMS Web Interface resources. Next slide, please. Please note that the 2020 materials providing information on MIPS Quality Performance category are available on the Quality Payment Program Resource Library. We encourage reviewing these resources if you have questions on quality requirements and measures. We'll continue to communicate any future postings in upcoming messaging. Additionally, the Help and Support webpage on the Quality Payment Program website contains links to materials such as videos, webinars, and online courses, as well as other items to help with reporting and development. Next slide, please. This slide contains links to resources available for Shared Savings Program and Next Generation ACO model. We encourage you to review these materials available here for more information. Next slide, please. If you need additional assistance, please refer to the contact information listed on this slide. Next slide, please. CMS has no-cost resources and organizations to provide help to clinicians who are participating in the Quality Payment Program. Learn more about technical assistance by following the link on the slide. Next slide, please. Now, just before we head into the question and answer portion of this call, if you're interested in providing feedback and collaborating with CMS on the Quality Payment Program, we encourage you to participate in our human-centered design efforts. To get involved, please email your name, title, topic of interest, and organization to qppuserresearch@cms.hhs.gov. Now I will hand things over to Haley Burnside to begin the question and answer portion of this call.
Great, thank you, Sandra. We will now begin the question and answer portion. Please submit your questions via the questions tab please submit your questions via the questions tab on your screen or raise your hand and we will unmute your line. All right. Going into our first question, will we be required to produce documentation in case of audit for Prev 7 pre-fills?
And this is Deb. Just to kind of point you to the FAQ document that's posted on the qpp.cms.gov website within the resource library. One of the answers does include if influenza immunization data has been pre-populated for a patient, it does not need to be validated. If the group, virtual group, or ACO is selected for an audit, the group, virtual group, or ACO will not have to provide medical record documentation for pre-populated influenza immunization data. Thank you.
Moving on to our next question on Prev 12. For depression screening, is the exception situations where the patient's cognitive capacity, functional capacity, or motivation to improve may impact the accuracy of results of standardized depression assessment tools. For example, certain court-appointed cases or cases of delirium considered its own category, or is it considered a medical reason exception?
Hi, this is Katie from the PIMS team. So in this instance, that would be considered a medical reason. Thank you.
All right, thank you, Katie. And I think we will go to our phone line now for some incoming questions. And Joanne Ryan, your line is now unmuted. Joanne, you may need to unmute your personal line to ask your question.
Okay, thank you. We are an ACO and we have one provider within our ACO who has been granted an approved hardship exemption related to COVID. And they are unable to report any quality measures on their selected patients. And many of those patients are showing up in the minimum ranking for the ACO. So when we look at the ACO's completion rate, it is showing incomplete, and the ACO has not met its minimum reporting. What should be done with this patient population, if anything? Should they just be left blank because there's no reporting? Should they be marked chart not available? Should they be marked not applicable? How should this patient population be handled?
This is Fiona from the Shared Savings Program. Your provider that has the exception, that exception is for MIPS reporting, I presume, because it wouldn't, I'm presuming that it's for MIPS reporting. Yes. That does not apply to the Shared Savings Program. The ACO is required to report on all of the patients in the patient sample. If you do not have access to the record, then it is applicable to be able to do medical record not found. But as the ACO, you are required to report on all the bennies in your population.
Okay, thank you. I appreciate your advice.
Okay, and our next question comes from Christina Tomaselli. Christina, your line is now unmuted. And Christina, you may be self-muted. Okay, we will try to come back to Christina. We will move on to Amy Allred. Amy, your line is now unmuted.
Hi, my name is Amy Allred. I'm calling from Chess ACO. And one of our ACOs this year, we had something very unusual happen and that I can't get a clear answer on when I've submitted tickets as well as called. For our MSSP ACO, we had around 38 patients show up that were listed as an unknown clinic ID. So what I did is I pulled those patients down and I bounced those up against our data warehouse to look if we've ever had those patients attributed. And we had all the patients attributed to one of the 10s in that ACO during performance year 2020. They had previously told me to follow the instructions in the web interface guide and go in and fill out information about those unknown TINs, but when you go in, there's no TINs listed. It just said it has all the valid TINs listed and then just one named unknown. So my question is, because I don't want these to be gaps or skips when I upload the rest of the data, what I had planned on doing is if we can find the data in the EMR, we were going to go ahead and work those patients. And if those patients don't exist in the EMR, we were just going to put that we couldn't locate those patients. Will that suffice?
Hi, this is Sandra. Oh, go ahead.
No, go ahead, Sandra. Don't worry.
This is Sandra from the Shared Savings Program. It would be helpful if you have submitted previous tickets, if you could provide your ticket number. And just as a reminder, the provider and clinic information may not be available in the web interface. However, if the beneficiary is listed in the web interface, they have been assigned to your ACO. So that may be helpful. And I don't know if Oslam could weigh in on if they need a TIN in the file when they upload or not. I'm not sure about that technical piece.
Sandra, could you please repeat the question?
Yes, I think the questioner was asking if they needed to identify the TIN in their upload file if it's not available within the web interface, and please clarify if I misunderstood that. And I wanted to know if they needed to have that information available in their file when they upload it.
So they can download the beneficiary sample file from the web interface, and that downloaded version would have all the necessary information the file would need for upload.
So if the if the clinic ID says unknown, will those upload correctly if we add the data in the EMRs that we located the patients in?
So I think the best thing would be to open a help desk ticket and have that escalated to the web interface team, and we can look at your information and question in detail and provide you the specific answers that you're looking for.
Should I reply if there's already an existing ticket and existing calls out there? Should I reply to those and ask them to be escalated?
Yes, that would be great. You can use your existing ticket and ask that to be escalated to the web interface group.
Okay, thank you so much.
Awesome. Can I ask a question? Would it be possible for the lady to actually give you the ticket number so you could look it up and do it that way so we can expedite this?
Absolutely.
Yes, ma'am. Would you be able to put your ticket number into the chat or into the question box so we can follow up that way, please?
Yes, I certainly can. Thank you so much.
You're welcome. Thank you.
Bye-bye.
Okay, great. And then our next question comes from Heather Dice. Heather, your line is now unmuted. Okay, we may need to come back to try Heather again. So we'll move on to our next questioner. We'll try Christina Tomaselli again. Christina, your line is now unmuted. Okay, I think we can go ahead and move to a question from the questions box. And this is on Prev 13. If the provider feels that the patient doesn't need the statin based on an old diagnosis of ASCVD, can that patient be excluded?
Hi, this is Katie from the PIMS team. So with this one, the first thing that you would want to confirm is that for population 1, the patient has a diagnosis of ASCVD active or history of at any time up through the last day of the measurement period. So if they have that history of ASCVD, it would pull them into the denominator. To address the second part of the question, if a patient refused a statin, it would be considered performance not met. There would still need to be an order or prescription of a statin to meet the intent of the measure. Thank you.
Thank you, Katie. And our next question is on MH1. Our EHR has all 9 questions from the PHQ-9, but the tool is not labeled as such. Is it acceptable for us to use?
Hi, this is Angie from PIMS. We can't speak to specific medical record documentation. For the measure specifications, there must be documentation to support that a PHQ-9 or PHQ-9M was the tool that was used, as those are the only acceptable tools that can be used for the measure to show remission. Thank you.
Great. And then our next 2 questions are on PREB6. The first question, if a patient has a DX of dementia but does not take medications listed on the sheet, can it still be an exclusion? And then the second question is, if a patient refuses the colonoscopy or other colorectal screening, are they still considered a fallout, or can we exclude them?
Hi, this is Katie from the PIMS team. So in order to report a denominator exclusion, you would need to confirm that the patient meets all criteria for that exclusion. So if they don't, it would not be appropriate to report that. And for PREB6, there is no exclusion or exception for patient refusal. So in that instance, it would be considered performance not met if the quality action was not completed. Thank you.
All right, and our next question, is state immunization registry okay for documentation of PREB7?
And this is Deb. Yes, that's acceptable as long as you have medical record documentation that supports the vaccine was received during the appropriate flu season. It really gets back to your medical record documentation and the fact that it supports that the flu season being measured is the one that documentation is tied to. Thank you.
All right, thank you. And for our next question, on the statin measure, if the patient only has criteria 3, diabetes, but there is no lipid panel in the record and therefore we don't have an LDL level, what is an appropriate way to answer this measure?
Hi, this is Katie from the PIMS team. So in this instance, you would just want to follow the flow of the measure specification. So there's a question that says determine if the patient has the LDL-C of 70 to 189. If they did, you would select yes. If they do not have an LDL-C of 70 to 189 documented, you would select no to that question. Thank you.
And for our next question, is it appropriate, what is the best way to handle beneficiaries that are marked deceased in 2020?
This is Angie from PIMS. You would do that during the patient confirmation step right at the beginning. And that's when you determine they would not be you'd select not qualified for sample. And then you may enter the last date of you would enter the date that the patient was deceased. And if that's unknown, then you can enter the last date of the measurement period, 12/31/21. And I believe there's a way that you select a reason, and you would select deceased if the patient died during the measurement period. Thank you.
And our next question is on HTN2. If the most recent visit with BP is an oncology infusion appointment, can we use the previous office visit with BP? Their BP is higher at infusion appointments than all other OBs.
Hi, this is Carol. So you would only go to the previous visit if the diagnostic test or therapeutic procedure, meaning the chemotherapy, required a change in the diet or a change in medication on or 1 day prior to the infusion. It would be appropriate then to move to the next most recent blood pressure, but otherwise you would just report that value.
Okay, thank you. And our next question is, for year 2020, can you please clarify every quality measure that is pay for performance?
So this is Fiona from the Shared Savings Program. So I'm guessing that you may be an ACO because you're asking about pay for performance. It would actually be easier to talk about the measures that are pay for reporting rather than measures that are pay for performance, because out of the 23 measures in the Shared Savings Program measure set, there are the caps for MIPS, the caps for ACOs measure, the ACOs will be receiving full credit. So those measures will just automatically be credited 2 points if you complete web interface reporting. And then in the web interface, you have Prev 12, Prev 13, and MH1 that are paid for reporting. And for Shared Savings Program ACOs, there is also one claims-based measure, ACO 43, that is pay for reporting for performance year 2020. The rest of the measures are all pay for performance. And if you go, we can send you a link into the chat. We can put it in the chat with a link to the actual rule, so it'll show you which measures for 2020 are pay for reporting or pay for performance, or we can even link you to the benchmark document, which is probably be easier, so that you can see which measures in there are pay for performance versus pay for reporting. Thank you.
And then for purposes of MIPS, so those who are reporting as a group or a virtual group, we use the term that a measure is not scored. And sometimes, and in relation to the Shared Savings Program and Next Generation ACOs, we will also note that measures may not be paid for reporting, but for purposes of MIPS, the measures that will not be scored are measures MH1, Prev 12, and Prev 13. And we just want to note that you still need to report and meet all the reporting requirements for each measure, even if the measure is not going to be scored, or even if the measure is paid for reporting. Thank you, Lisa Marie. Moving on to our next question, can you please address the error that you get for Prev 10 and Prev 12 because the column headings were changed on the CMS template after it was available for download?
Hi, this is Aslam. The error was addressed in the system. So if you're using a template, older template, what you can do is take a look at the newer template and update the column headings in your old template to match the new one, and you'll be able to upload the file without an issue. Thank you.
And our next question. When I download the measure rate report, I don't have the row labeled measure score, as was shown in the screenshot when referencing the Prev 10 error. Why does this look different? And I can repeat the question if needed. Yes, Haley, that would be great. Okay, great. So the question was, when I download the measure rate report, I don't have a row labeled measure score, as was shown in the screenshot when referencing the Prev 10 error. Why does this look different? Aslam, would you be able to speak to that?
Lisa Marie, we can take a look at it and in the system. I am not aware of a difference, but we can take a look at it and let CMS know.
Okay, and for this individual who submitted this question, if you submit a help desk ticket, we'll be able to provide you the information relative to your question in the event that we're not able to do so during this webinar, which I don't think we'll be able to do so since the product team will need to go in and investigate. But please submit a help desk ticket, and we will address your help desk ticket once we receive it through the Quality Payment Program Service Center. But please, please submit a ticket so we can get information to you for that. Thank you.
Oswald and Lisa Marie, should they have that escalated to the product team?
Well, the question, when it is submitted to the service center, they will know who to send it to given the context of it, because it is technical in nature, so they will know who to send it to.
Okay, thank you.
And also, just for the individual who submitted that question, please also identify if you're part of an ACO, because if you're an ACO, we just want to, again, make sure that we're providing all the information relative to the way in which you are reporting or participating in the program. So that'd be great. Thank you. And moving on to our next question, would a note during the measurement period indicating a past medical history of depression be acceptable to put a patient in the denominator?
Hi, this is Angie from PIMS. I am assuming that this is a question for the MH1 depression remission at 12 months measure. The patient has to have major depression or dysthymia during the denominator identification period. So I would refer you to the denominator codes in the 2021 MH coding document for diagnosis codes acceptable for the denominator, and to match those up. And it would have to be included there for that patient to be in the denominator, as well as they would have to have at least one or more PHQ-9s or PHQ-9Ms administered during that same denominator identification period, or they would not be eligible for the denominator. Thank you.
Okay, and our next question is, are ACOs getting full scores for CAPS measures, or will the domain be reweighted?
This is Kristen from RTI, and ACOs will be getting automatic full credit for the CAPS measures. Thank you.
And our next question, if the most recent visit does not have a BP documented, can we abstract the BP from the visit before?
Yes, you may. So if your blood pressure is not found, hi, this is Carol, by the way, from the PIMS team. If a blood pressure is not found at the most recent visit, you may look back to the next most recent visit within the measurement period where a blood pressure was actually documented. You can also see page 10 for additional numerator guidance within the hypertension 2 specification.
Okay, thank you. And we will go back to the phone line. So Zayshawn Khan, your line is now unmuted.
Yes, hi, can you guys hear me?
Yes, we can hear you.
Okay, perfect. Yes, so we are in APM, and I was wondering on, we have an understanding that the measures that we're submitting through the web interface, there's some sort of improvement bonus on there as well from last year. Is there any changes to that because of COVID?
So this is Fiona from the Shared Savings Program team. So are you asking for, with regards to being calculation under MIPS, having it calculated under the Shared Savings Program?
Under the Shared Savings Program, that's correct.
Okay. The scoring takes into account any improvement that you would have on any of the measures you reported from the prior year. So that is not changing because of COVID. So it will be taken into consideration when we do the calculation for the 2020 annual quality reports, yes.
Got it, and that's only going to be for the performance measures, right?
It's only for the performance measures, correct.
Got it, thank you.
And then moving on to Lisa Shonis, your line is now unmuted.
Hi, can you hear me?
Yes, we can.
Hi. So I was just responding to the woman that called in, I don't know, about 7 questions ago. She had an unknown clinic ID with beneficiaries. We had the same thing. So we had them listed on our download from the CMS portal, those beneficiaries, and they were, most, if not all, were in our medical record system of Epic, in our EHR. So we filled out what we could, and I loaded them without any issues. So I just wanted to share that.
Great, thank you. And then moving on to Josephine Osifo, your line is now unmuted. And Josephine, you may need to unmute your personal line to ask your question.
Anna, can you hear me?
Yes.
Okay, hi everyone. I wasn't really asking a question. I was just going back to some questions about the statins for the patient with cardiovascular disease. And I know they answered the question, but I wanted to ask, so if those patients refuse and they have reasons because they're reacting, can we still use the exclusion code?
I'm sorry, was this for the Prep 13 measure? Just want to clarify.
It was for the ASCVD statins, for those members who would use statins. So I was asking if they have reaction to statins, they have myalgia or one of those reactions.
Sure.
Can those codes be used to exclude them?
Okay, so in the instance there's a true medical reason that they weren't taking the statin, there's a list of denominator exclusions and exceptions on page 6 of the Prep 13 measure specifications. If there's documentation supporting that a statin wasn't prescribed or was refused due to one of the reasons listed in the measure specification, it would be appropriate to report the exclusion or exception, whatever is applicable in that scenario. In the instance a patient just flat out refuses, that's where it would, there's no exclusion or exception for that scenario. In that case, an order or prescription must have occurred during the performance period in order to meet numerator compliance.
Okay, thank you.
And then our next questioner is Busan Carl. Your line is now unmuted.
Hi, good afternoon. Bhushan Karli from Ascension. We are trying to estimate where our score will be. We've collected all the data and put it in the CMS system. Just wondering if a couple of measures that are considered pay for reporting, will we get quality improvement points for this year? For example, PREP 12. I believe it's ACO 18. It's has been reporting for many years. But if our quality score actually improved or declined, is that considered in the calculation for the QI points?
Atia, could you answer this question? Sorry.
Yeah, sorry, can you repeat that question again?
Okay, ACO 18, depression screening, it is pay for reporting. It has been for, I think, several years. But we want to understand if our quality score improved significantly or declined significantly. Does it factor into the math for the overall quality score? The QI
Yeah,
point.
even though that measure is paid for reporting this year, it was also in the program the previous year, so it will be included in the calculation of quality improvement for the domain quality improvement point.
Right. Yeah, we just wanted to confirm that. Yes.
Yeah.
Thank you.
Yeah. Thank you.
And Rachel Herbert, your line is now unmuted if you'd like to ask your question. And Rachel, you may be self-muted. We will try to come back to Rachel, but I believe we may have a follow-up question from Zaishan Khan. Your line is unmuted.
Yes, hi. Well, I got two questions now because from the last question that was just answered, I guess the improvement activities, first question is improvement activities, just to confirm, are also based on reporting measures, not just performance measures?
Yeah, if it was a reporting or paper reporting measure that was in the prior year and didn't have and wasn't changed, so the measure was in the program, both the previous year and the current year, it would be included in the calculation of the quality improvement reward points.
Got it, understood. And second question is, what are those thresholds? Like, is there a certain threshold on what's considered improved, or is it just if it's just one patient more than last year or a percentage more than last year, it's an improvement?
I would refer, it's based on the Medicare 5-star methodology, which is detailed in the 2020 quality measurement and methodology resources document. So I would reference that for details on specific details on the calculation.
I'm sorry, can you repeat that documentation one more time? Or I think she just put it in.
Yeah, we can put it in the chat, but it's the 2020 quality measurement and methodology resources document. And I believe you can find that on the Shared Savings Program website.
Thank you very much. All right, thanks.
Yeah, thank you.
And our next question from the chat box is, for Care 2, if the patient is in long-term care and hasn't seen the provider, but there is documentation in the nursing home records that the patient is not ambulatory, is that sufficient for exclusion?
Hi, this is Angie from PIMS. I just want to kind of go back to one of the frequently asked questions that I read today. You can report based on any medical record documentation you have for this patient, regardless of the setting for this measure. So if at the most recent encounter during the measurement period, there's documentation that the patient was non-ambulatory, then it would count for the denominator exclusion. Thank you.
And we will go back to the phone line. Rachel Herbert, your line is now unmuted if you'd like to ask your question. And Rachel, you may need to unmute your line. Okay, we will try to come back to Rachel. See if we have any other questions coming into the questions box. As a reminder, to submit your question, please submit it into the questions box, or you can raise your hand and CMS will unmute your line. Okay, looks like we just got another question on scoring for ACOs. Will the ACO reported score be used to calculate improvement, or in the case where a higher mean score is assigned because of the extreme and uncontrollable circumstances, be used for improvement, whichever is higher?
Achia, can you please take this?
Yeah, I'm sorry. Can you repeat the question?
Sure. So they're asking, will the ACO reported score be used to calculate improvement, or in the case where a higher mean score is assigned because of the extreme and uncontrollable circumstances, be used for improvement, whichever is higher?
Yeah, so in order to calculate the quality improvement, the actual reported measure performance is used to calculate the quality improvement. And then once the final quality score is calculated for ACOs, then it's determined whether ACOs will receive the mean. So the quality improvement is calculated off of the actual reported
measure performance. So it's before the mean is applied. I hope that answered the question. Great, thank you. And we will stand by for our next question. Okay, and we did get another question come through. So this question is, could you please confirm for 2020 year CAPS measures would have to be reported?
So for the shared savings program, we waived the requirement to report CAPS. Are you asking about whether CAPS will be used in the calculation of the MIPS quality performance of the MIPS quality performance category score, and whether they need to be reported for MIPS? Because I don't know if we have anybody on the line that can actually address that question.
And then just for the MIPS side, the CAPS for MIPS survey for MIPS is optional. So if a group had registered to do it, then they conduct it, but it's not required in terms of mandated as in previous years under the as required under the shared savings program, just because there are differences between shared savings program and how groups and virtual groups participate in MIPS. Thank you, Lisa Marie. Again, we will just stand by for our next question. And as another reminder, to ask a question, please submit it via the questions box or raise your hand and we will unmute your line.
Hi, this is Aslam Tassel. While we are waiting for the next question, I can provide an answer for one of the questions that came in earlier regarding the measure rates report. So if you are logged into the system as an ACO, reporting as an ACO, the measure rates report will not show any scores. However, on the measure rates report page, there's a link that says view measure rates report with MIPS scoring. If you click on that, that version of the report will show the score. However, if you're not, again, if you have not clicked on that link and you're looking at the measure rates report as an ACO, by default, neither the system or the downloadable version will show a score. So that was the difference on what you're seeing in the system and what we showed in the slide. So there is no issue in the system. It's just a different view for an ACO versus a group. So you can view the version with the score if you, again, click on that view measure rates report with MIPS scoring. I hope this helps answering the question. Thank you.
Great, thank you. Thank you, Aslam, and we did get another Oh, sorry. I just want to say thanks, Aslam, for providing that clarification, because again, I think it's important for those on the call to understand that there are differences between ACOs, particularly on shared savings program, and those reporting as a group or a virtual group. And as Aslam noted, in that report for ACOs, you will not see the scoring column, whereas if you're reporting as a group, as shown in the screenshot from our presentation, you would see that column. Again, thanks, Aslam. Okay, great. Then we did get a couple more questions. So our next question is, Will all ACOs be entitled to the national average score if their scores are poor? If not, is there a map that shows the ACOs that will not get the national average? What are the national averages?
So I presume you're asking if with regard to the extreme and uncontrollable circumstances for shared savings program ACOs. For performance year 2020, all ACOs are considered impacted by the COVID-19 PHE, and the EUC policy applies to all ACOs. And then if an ACO reports, they will get the higher of their own quality score or the 2020 mean quality performance score, or if they are unable to report, they will receive the 2020 mean ACO quality score. Thank you. Oh, and to answer, there's a question above this question, which says, what mean scores will be used, 2019 or 2020? I just answered that. It is the 2020 mean quality performance scores that will be used when we apply the extreme and uncontrollable circumstance policy to ACOs.
Great, thank you. And our next question is on the MH1 measure. We have an adult patient with Down syndrome who does not understand the PHQ-9 screening questions. He does not live in a nursing home or meet the other exclusion categories. We simply answered no, he did not have an index PHQ-9 rather than excluding him. Is that correct?
This is Deb, and basically, yes, that's correct. The thing to keep in mind with MH1 is that when those patients are sampled, those patients are sampled based on diagnosis and encounter types. There is no way to identify within claims the PHQ-9 or the PHQ-9 greater than 9 score. So in essence, what you're doing is you're confirming denominator eligibility. So in cases for MH1, if a patient does not have a PHQ-9 score or they don't have a PHQ-9 greater than 9, that patient is not considered denominator eligible for that measure. So in your scenario, what you did was accurate. You would not want to claim an exclusion that's not relevant for a patient. And in this case, you don't have that PHQ-9 greater than 9. And so you would just select the no. Thank you.
Thank you. And we will go back to the phone line. So Jennifer Sexton, your line is now unmuted.
Yeah, hi, I have a quick question. Where can we find the national averages for 2019? And more importantly, when will the 2020 means performance scores be published by CMS?
Are you asking as part of our ACO?
A few minutes ago, you referenced the national averages, the mean national averages, which will be applied for all ACOs. I'm looking for the 2019 national averages, and then I'm also wanting to confirm when the 2020 national averages will be published.
So they don't get published. It actually is once we do the quality scoring and the annual quality reports go out, it will be in those annual quality reports. RTI, please correct me if I'm wrong, but we actually have the mean for 2019 should be in our public use file, which is on the cms.data.gov site. Is that correct?
Yes,
this is Kara. Yes,
I'm sorry.
Yeah, it is in the public use file, and we can post that link to the chat. It would have the ability to calculate the mean at the measure level.
Moving on to Deborah Mattingly, your line is now unmuted. And Deborah, you may be self-muted. Okay, we will try to come back to Deborah. And then moving on to Fatima Pichera, your line is now unmuted if you'd like to ask your question.
Yeah, hi, can you guys hear me?
Yes, we can hear you.
Hello. Okay, so our ACO, we have submitted all the measures. My question is, can we see our quality scoring on the QPP website anywhere, or do we have to wait till after the March 31st? Like, what's our quality report scoring?
Are you asking about how your quality would be scored under the shared savings program?
Yes, yeah, because we finished our submission. So I was wondering, is it already available to see somewhere on the website, or do we have to wait?
You will see your quality score when the 2020 ACO annual quality reports are released. And generally, they normally get released with the embargoed financial packages in August.
Okay, all right, thank you.
You're welcome.
Okay, and we will try Deborah Mattingly's line once again. Deborah, your line is now unmuted if you'd like to ask your question. I do not think Deborah is coming through, so we'll check to see if we have any more inbox questions at this time. I'm not seeing any other questions at this time, but do want to just remind attendees to ask a question. Please submit your question using the questions box or raise your hand and we will unmute your line. Okay, we did get one more question. Will the mean scores be applied on a measure-by-measure score or on the overall quality score?
For the shared savings program, the mean is for the overall quality score for the extreme and uncontrollable circumstances policy.
Thank you. We will just continue to stand by for our next question. We'll go back to the phone line. Crystal Lamogas, your line is now unmuted. And Crystal, you may be self-muted. Okay, we will try to come back to Crystal. Not seeing any other questions in the inbox at this time, so we would like to give just one final reminder to ask a question. Just please submit your questions via the questions box or raise your hand and we will unmute your line. I think we have one more phone line question, and Deshaun Khan, your line is now unmuted.
Hey guys, sorry for bombarding you with questions on this improvement activities, but I just wanted to understand one more portion of this. So once we hit the 90th percentile for any measure, does that mean that there is no improvement possibilities there? Like if I scored a 92 last year and now I'm a 94, there will be no improvement activities associated with that. Is that correct?
If it was still a significant improvement, you could still earn points, but if there's an exception where if it you had significantly declined but were still above the 90th percentile, you would be held harmless. So if you still significantly improve, that you could still earn, it would still contribute toward the award, but if you significantly declined, but you still scored above the 90th percentile in both years, then you would be held harmless. And it wouldn't, does that make sense?
That makes sense. Yeah, that makes sense. Okay, got it. Thanks.
Thank you. Okay, and we did get another question. For MH, can the PHQ-9 greater than, or I'm sorry, for MH, can the PHQ greater than 9 and the DX of major depression be considered separately as long as they are in the time frame, or is the index date the first time they occur together?
Hi, this is Angie from PIMS. Basically, it is the first time they occur together. The diagnosis may occur on a different date than the PHQ-9, before or after, but it'll be the first instance that they both occur together. Let me see, the specifications say the first instance of the PHQ-9 that's also associated with the diagnosis of major depression or dysthymia. So as long as they're both during the denominator identification period, it doesn't matter which one happens first. It's when you see both of those things documented. So it'll either be the date maybe they had a PHQ-9 first and the major depression diagnosis then was made after, then that would be the date, the index event date. Or maybe they already had the diagnosis, but the PHQ-9 greater than 9 during that denominator identification period came second, and they already had the diagnosis, and it would be the date of the PHQ-9. So it could be either, as long as they're both during that time period. I hope that helps clarify for everybody. Thank you.
Angie, this is Deb. I think the PHQ-9 can happen before. I mean, basically you have to have a diagnosis of major depression and then have the PHQ-9. So you read a part of that specification. I believe it's the denominator is specific to patients with a diagnosis of major depression or dysthymia. So you would look for patients that have an elevated PHQ-9 concurrent with or after the diagnosis. The elevated PHQ-9 can't precede the major depression or dysthymia diagnosis. So it's not as easy as that you can have one happen at any time, one or the other happen at any time within that denominator identification period. And it doesn't mean that both have to occur for the first time on the same date, but your PHQ-9 greater than 9 has to be associated with a diagnosis of major depression or dysthymia. Would that be accurate? I think that is accurate. And if the caller has any additional questions, you can certainly submit a quality payment program ServiceNow case, and we will get that to you in writing. But that information is spelled out within the posted specification, which can be found on the qpp.cms.gov website within the resource library. And that resource library, if you've not been to the QPP site, just scroll down to the bottom and you'll find the resource library link. And then you'll be able to even look for just a particular program year, and you can specify you're looking for quality measures, and that should help you narrow down to the web interface specifications. Thank you.
Great, thank you. And our next question is for the Advanced APM Shared Savings Program. Are bonus points and improvement points awarded for MH1 and PREV 13?
So for the Medicare Shared Savings Program, those measures are included in the Quality Improvement Reward if you have the prior year data to compare to. But I also just want to reiterate that the Quality Improvement Reward points are calculated at the domain level. So the points aren't awarded at the measure level, but rather at that overall domain level. But these two measures are included in that quality improvement reward calculation. Thank you.
And Fatima Yusuf, your line is now unmuted if you'd like to ask your question. And Fatima.
Yeah, that's for me?
Yes, we can hear you.
So the question was regarding the MH and the depression screening. I just want to make clear, is it for the remission one or is it for the screening when you were talking about the PHQ-9? Because PHQ-9, of course, if it's more than 9, I mean, we were talking about the depression that's already been there.
Right.
Yeah.
Right. We are referring that question that was originally answered, and there's been a couple of follow-ups here that I can kind of address all at the same time. That was specific to MH1 because MH1 requires a PHQ-9 or a PHQ-9M of greater than 9 to even be included within the denominator. PREV-12, the depression screen, does not have a specific tool that has to be used or even a specific score. It really needs interpretation by the clinician whether or not that screening is considered positive or negative for depression, and then that measure requires the recommended follow-up. So you're right, the response that I provided earlier along with Angie was specific to the MH1 depression remission measure.
Okay, yeah, that's, I was just like, so if there is a, what do you call a diagnosis, then we have to go into the detail. Okay, I got it, thank you.
You bet. And then to kind of go along with the other follow-ups that have come in, there's one about what does associate mean in the instance of the MH1 when it comes to whether a PHQ-9 and an MH diagnosis has to be on the same day or whether they can be on separate days. Basically, associated just means you will have to have you'll have to confirm the diagnosis of major depression or dysthymia during the index period and any time on that date or after, as long as that diagnosis is still applicable. If there is a PHQ-9 greater than 9, you would be determining that that patient is considered denominator eligible, and you would begin looking for the remission within the appropriate time frame. Within the flow of the spec, it does say the date in which the first instance of elevated PHQ-9 or PHQ-9M greater than 9 and a diagnosis of depression or dysthymia occurs during the denominator identification period, and it includes the dates. Patients may be screened using PHQ-9 or PHQ-9M up to 7 days prior to the encounter, including the day of the encounter. And then additionally, there is some information, and I'll reread that for your convenience, but it is within the specification and can be found on the qpp.cms.gov website. Since the denominator is specific to patients with a diagnosis of major depression or dysthymia, you should look for patients that had an elevated PHQ-9 concurrent with or after the diagnosis. The elevated PHQ-9 cannot precede the major depression or dysthymia diagnosis. The index date would be initiated by the first elevated PHQ-9 that is also associated with a diagnosis of major depression or dysthymia. And if it helps, keep in mind that what you're really looking for within MH1, the depression remission measure, is you're holding clinicians accountable to a patient who has a depression, major depression diagnosis or dysthymia diagnosis and a positive PHQ, not positive, but a greater than 9 PHQ-9 or PHQ-9 score to helping that patient achieve remission within a set period of time. So if a patient, let's say, was being screened for depression, they have no depression diagnosis, and within your PREV-12 measure, you're finding that, hey, I have a PHQ-9, the result is greater than 9, the provider has written down that this patient is positive for depression, and I'm recommending a follow-up of medication. You're not going to want that same patient who was just at that point in time maybe identified as depression, but not major depression or dysthymia, to be held accountable to remission. So the key in all of these cases, because there could be times they do work together, is to really look at your medical record documentation and look at the measure specification, the measure specification flow that's part of the specification, as well as the coding. And those things combined should help you find the answers that you need. Thank you.
Great, thank you so much. And we do have just a few more minutes left of this webinar, so if there are any last-minute questions, please submit those to the questions box or raise your hand and we will unmute your line. And looks like we have a follow-up question from Fatima. So Fatima, your line is now unmuted.
Not a follow-up, just regarding the 2022, the 3 measures that we are going to be talking about, is it something that finalized yet or not? Like the depression screening, the blood pressure, and the HbA1c.
Are you asking regarding for shared savings program?
Yep.
Yes, that was finalized in last year's rule.
Okay, thank you.
And then we did get another question. Will quality improvement points be awarded for the CAP survey MSSP related question?
For Medicare Shared Savings Program, there will be no quality improvement points for the CAP survey because ACOs will be just receiving automatic full credit for all the measures in that domain. No additional quality improvement reward points will be added to that.
I am not seeing any other questions or hands raised at this time. Oh, we did just get one more. For MH1 depression is the same code as major depression, so we can consider diagnosis of depression the same as major depression.
And this is Deb again. Those codes are actually not the same that we're aware of, and we have spoken to the, excuse me, the measure developer of MH1, and they are very specific about what codes are considered major depression. If you're finding something you think is the same, I would recommend a ServiceNow help desk case, and we can, excuse me, further look into that for you. Thank you.
Okay, and just want to do one final last call for any remaining questions. If you have any, please submit them via the questions box. Okay, I'm not seeing anything else, so Lisa Marie or Sandra, I will toss it back over to you to close out the call.
Thank you, Haley, and thank you all for joining us today. The slide deck recording and transcript from today's call will be available on the Quality Payment Program webinar library in the next 2 weeks. Please submit any outstanding questions to the Quality Payment Program Service Center at qpp@cms.hhs.gov. The same subject matter experts on the phone today will assist you when contacting the QPP Service Center. Thank you.
We can conclude today's call. Thanks.